Good afternoon, and thank you all for joining us today. My name is Dr. Kate Armante. I'm the Chief Innovation and Education Officer at the Institute for Healthcare Improvement. I want to start by thanking the 6 foundations for hosting this crucial discussion today. Today, we're going to talk about financing a complex care model, and we'll give a bit of background about that in just a moment. During the webinar, feel free to submit any questions that you may have at any time through the Q&A button at the bottom of the screen. So before we introduce our panelists and get into the discussion, here's a bit of background on what we'll be talking about for the next hour. In 2017, the National Academy of Medicine released a report on effective care for high needs patients. High needs patients they defined as the 1% that cost 20%, the 5% that cost nearly half of our national resource in healthcare. And while these patient populations are certainly heterogeneous, the National Academy has identified several common features. These individuals accrued considerable costs. They utilized care with greater intensity than others, and they suffered many functional limitations. National Academy's authors offered a useful review of evidence-based care models, the models that have proven the most successful in addressing or meeting these complex health and social care needs of the individuals that suffered them. And while many of those models are now curated and presented on the Better Care Playbook, the Better Care Playbook is a website which contains all of the latest and best evidence around how to take care of individuals with complex needs. It can be found at bettercareplaybook.org. Perhaps the most frequent question that we've gotten on the playbook is the question about how to create a strong business argument to support initial investment in complex care and allow for long-term alignment of financial incentives. That's what we'll be talking about today, how to make the money work so that we can provide better care and better of this more evidence-based care to complex patients that desperately need it. Our discussions today will explore different opportunities and approaches that health systems, payers, and government agencies have taken to building a sustainable approach to complex care, including exploration of where federal and state level policies currently stand and where they're likely to go. With that, I'd like to welcome our 3 distinguished panelists. First off, Dr. Ken Coburn, CEO and Medical Director of Health Quality Partners. Welcome, Ken.
Thanks, Kater. Hi, I'm the CEO Medical Director of Health Quality Partners, and we're a 501c3 nonprofit.
Before you get into all of it, I want to introduce the other panelists, and then I'll come right back to you, if that's okay with you, Ken.
Sorry.
So Ken, welcome. Ms. Milena Ingram, a Senior Vice President for Policy and Government Affairs at Milena Healthcare. Welcome, Carolyn. Happy to have you. And Dr. David Pryor, Executive Vice President and Chief Clinical Officer at Ascension Healthcare. And so what I'm going to do now is I'm going to turn to our panelists and give them each a chance to set the stage for our conversation. We're going to start with you, Dr. Coburn. Please go ahead and go ahead with your introduction and your initial opening remarks about the topic at hand here. Thanks, Dr. Coburn.
Sure. Sorry for overzealousness. Yeah, I appreciate having the other panelists weigh in on this topic because it's a challenging one, to be sure. And the perspective that I come from is heading up a nonprofit that has focused largely on doing the R&D required to try and figure out what kinds of models are effective. As Kater said, the playbook helps identify some of those, and there's a lot of emerging work on this. But to think about financial sustainability and financing these models, it's really, it may seem self-evident, but it's really important to start with a model that has effective outcomes in terms of reducing avoidable complications and costs to this high-risk population, complex needs populations. And I think around effectiveness, there's a growing evidence base that I would recommend everybody take a look at and critically assess for yourselves and try not to shortcut that. And then even if you've identified something that's effective, in order to be financially sustainable, it needs to be implemented in a way that in your setting, with whatever local adaptations are required, that effectiveness is reproducible. And that also usually requires a certain capability to target the population for which the model was originally designed and intended. So those are just some of the initial framework around effectiveness that I would recommend toward financial sustainability. The other couple things I just mentioned briefly are the time horizon. Typically, if you're depending on preventing enough events to accrue a dollar savings, you have to be realistic given your target population, your ramp up time, assembling a team and operationalizing that team, and enrolling, outreaching to and enrolling the target population. You have to be realistic about the time it's going to take to do all that, and then the time it will require to accrue enough prevented events, which obviously are hard to count, to be able to say you're beginning to have a financial impact. And on that count issue, another point I just make briefly is the measurement system and management system for these kinds of approaches. To be able to credibly negotiate terms and contracts and payment systems, at some point in time, you're going to need to create methods by which, usually through the construction of a non-randomized comparison group or benchmark, you can measure your effectiveness with the target population. That is a complicated and challenging endeavor all unto itself, and some of the contracts that we've had have included literally the methodology for doing that and the spreadsheets and algorithms just to be able to measure impact in some of the financing models. So those are my initial thoughts around what it takes to do this.
Thank you, Dr. Coburn. We're going to come back to you for some additional details and thoughts about how to do this right and how to do this well. But let me bring Ms. Ingram into the conversation. Please go ahead and give us a bit about your work at Milena at this time and some of what you've seen in prior work in Medicaid. So go ahead.
Thank you. It's great to be here today talking about this subject. I've had a lot of time to work on it prior to my position at Milena, where I work as a senior vice president in charge of our policy and government affairs work nationally. I worked at the Center for Healthcare Strategies and worked with states across the nation on implementing programs around complex care and complex populations. And then prior to that was Medicaid director for about 8 years in the state, where we obviously struggled a lot with getting services to people who had complex needs and being able to move them into the community. I think in terms of looking at the financing and the topic of today's conversation, one thing that's really important that we have to all consider is what financing the model looks like and how you can do that around building what the person really needs to be able to live in the community around social determinants of health. There's a business case, of course, that can be made for that. There's research out there and studies. Studies have shown that the U.S. is underspending on social determinants of health compared to the EU, and we end up then paying about 2% more GDP in our annual healthcare costs and welfare costs combined. There's been a couple of very specific studies that have come out lately looking at the correlation between offering somebody food security through food stamp programs, or SNAP as some folks might know it, and seeing a reduction, a very clear reduction in terms of emergency room use among lower income adults when they're offered that additional benefit. That study, I think, came out looking at the state of Maryland and the cost around hospital utilization for older adults, was just recently published in 2018. The other study we see has come out, published by the American Hospital Association, and looked at the University of Illinois Hospital and Health System partnering with the Center for Housing and Health to provide housing services for people who are chronically homeless, but also seen as what we call super utilizers or emergency room utilizers. And they were able to significantly reduce the emergency room use and more appropriately shift folks to community-based services and lower cost healthcare clinics, and are looking at expanding that. So I think the business case is definitely there in terms of the literature. And so the next thing you have to kind of look at is what key areas of social determinants of health are important to invest in, that you're going to get the most bang for your buck in terms of some of these projects. As managed care companies, I've seen people doing lots of things across the board, but I think from our experience, the ones that we see the most reward in are things around food security, obviously, housing stability, employment, and then the other category, I would say, two others: environmental conditions, obviously playing a very key role, whether it can be in the house or in the neighborhood or even the community that somebody lives in. The problem is a lot of these are not financed benefits in the Medicaid program. And so there's different things that need to be done to be able to work with states to make sure that when you come forward to work on these programs that you're able to get some type of reimbursement for them. Otherwise, you're working at reducing the cost and not getting credit for that on the back end, and then you end up inside your organization not being able to get support to continue on with investment in these types of programs. And so some work that still needs to be done there for sure. You know, some specific examples that I've seen out there are working with states to make sure that value-added services like housing or like food security are added back in terms of the actuarial buildup of the rates to make sure they're considered in terms of capitation payments, and then make sure that states are focusing, as well as managed care companies and providers of care, on linking people back proactively to these types of services that are going to reduce poor health outcomes, but they're also going to help to create better linkages to care. We've seen, you know, even just announced, I think today or last night, North Carolina's waiver that they most recently got approved to be able to fund some pilot programs that focus on housing and employment engagement. So we're starting to see that start to move in terms of our healthcare system, but a little bit, well, more work needs to be done there. So I'll turn it back to you for our next panelist, and then be here for questions.
Yeah, thank you very much, Ms. Ingram. This is very, very useful opening comments. Let me turn it now to Dr. David Pryor. David, you've worked at large system for many years now, tackling some of these problems that we're wrestling with here. Do some of the things that Carolyn just mentioned about payment changes help? How are you making sense of this at Ascension and in your work?
Thank you, Kedar, and good afternoon, everyone. And I, too, enjoy the comments of my co-panelists and think there's a lot of gold in what they're saying. Ascension is the largest not-for-profit health system and the largest Catholic system in the country, with over 2,600 sites of care, including 154 hospitals, 165,000 associates, approximately 40,000 providers, of whom about 8,800 or so are employed. So the perspective I bring really represents that of a large delivery organization. Over the last 15 years, I've watched as delivery organizations have tried to move from financial models that reward value versus volume. In most instances, delivery organizations have contracts that represent both types of financial models, with the majority still in the fee-for-value world. I'm convinced that doctors really only practice one way. Many organizations have focused on trying to figure out how to practice within the context of a financial model. I don't think it works. Instead, we need to figure out the right way to practice and then figure out how to make the financial model support it. The right way to practice for patients with complex health and social needs requires a multifactorial intervention. I feel fortunate to work in a system whose mission is to provide care with special attention to the poor and vulnerable. And as an organization, we've committed to eliminating barriers to care that drive disparities in clinical outcomes by 2022. The approach we've taken is to focus on a number of areas where large disparities exist for poor and vulnerable populations, including chronic diseases like heart failure and diabetes, as well as cancer screening. When I think about business costs and the business case and barriers, I'd like to use an example to sort of frame the problem. And begin the understanding of what the barriers are these patients face. So the first step is really understanding the barriers they face. To do that in heart failure, for example, we surveyed 1,100 patients who had been admitted and readmitted, and then identified what barriers to care they experienced. Then working with our clinical colleagues, we designed a heart failure admissions reduction toolkit. So that's not heart failure readmissions reduction, it's heart failure admissions reduction, getting rid of the index admission. And the approach builds on our overall population care model that's segmented by clinical, functional, and socioeconomic needs. Here we identified nutrition, care access, and medication access issues as particularly important for heart failure patients. We then try to eliminate those barriers working with partners. We used Lyft, for example, for transportation barriers and did national contracts, but we also use community programs, and they tend to be different in different communities, but they can also be extremely helpful within a given community. So for example, for medication access, we helped create something called the Dispensary for Hope, which makes medications available. So that we're hoping that when we work in this way, it's going to enable us to not only understand what works, but how you can spread it effectively across the country in a national way. And so we've currently surpassed our expectations. We've currently eliminated about 18% of all heart failure admissions in our system. And that's about 8,000 heart failure admissions a year, and it includes a 17% reduction in Medicaid patients. And that's resulted in over 500 fewer Medicaid admissions. This is great for patients, and it's the right way to practice, but at the business model, it means significant reductions in revenue for our system and a contribution loss of tens of millions of dollars. It also means that since only the sicker patients are now being admitted for heart failure, our readmission rates are going up. They still are better than observed over expected of 1, but they're going up. So the net result is you have better outcomes for patients, lower healthcare costs for the population, and whoever holds the financing risk. But for us, it's the challenge is to figure out how do you finance the intervention costs and support the work. So the playbook is actually a great resource, I think, that can help people. It's a good place to identify strategies that have worked and may work in your environment. It's also likely that the implementation may require some tweaking, but it's a good place to start. Thank you.
Yeah, thanks very much, David. I think our experience with the playbook supports that view that while best practice models can be hosted on a site like the playbook, but there's always a degree of customization and adaptation that's required at the frontline level to adapt effective practice models to local environments. Let me now. We're gonna turn now to questions from the audience as well as questions that are we have prepared for each other. I just want to remind the audience that's on the Zoom platform just now how to send us your questions. You can, if you look just at the bottom of your screen of the Zoom screen, you'll see a Q&A button right there, kind of on the middle of the toolbar. Feel free to click on that, and you can enter a question or chat your question to all of us, and we'll pick some of those up and pose them to our panelists here. With that, I'm just going to begin with one question here. Back to you, David, just for a moment. You mentioned, the challenge here around generating a supporting financial model for the right way to practice, as you described it. There is only one way to practice. It's the right way to practice. How do we generate a model of paying for that right way to practice that is financially viable in the face of some of the things that you mentioned, with increasing concentration of sicker patients, rising readmission rates, some loss of revenue. I'm curious how at this time Ascension and yourselves are working through some of those challenges. What's the approach that you're taking at the institutional level, whether it's hospital or clinics or in combination? At a system level, how are you sorting through this? What's the approach you're taking to try to?
I think at the system level, we have to try and understand what the implications are going to be as a system as we implement changes that are successful, and then we have to figure out how to manage that and support that. We have a lot of initiatives that are in place to eliminate what we think is significant waste that's currently in the healthcare system and try and get our overall costs down. At the same time, however, I think it's important at the business model for us to be able to work with payers, if you will, or insurers or employers who are willing to look at not simply the individual unit cost of care, but the total cost of care. Either that is a full cap or a sub-cap model or bundles or other kinds of approaches. All of those can be amenable in terms of how we work. The ones that really don't work, to me, are really the shared savings kinds of programs and things. I think those are bridges. as you go forward, because they set a new standard every year, and at some point or another, you can't make it work. So I think it's either got to be a subcap or a bundle or a full cap or some kind of approach and partnership that works. The other piece that I think is interesting is that, you know, if you think about it sort of globally, when we look at the financing, we can look at financing as either and sort of three perspectives. One would be to say there's the unit cost for each service that's provided, and then there's the total number of units of service that are provided. And then I think, as Carolyn alluded to, there are these social determinant issues that may up the whole number of units that are required. And so there is the opportunity to think at a policy level about greater investments in social determinants or making that easier to do as you go forward. But at the same time, I think that even individual payers need to be looking at not only the unit cost, but the total costs, and understanding in some cases how you enable or allow providers to maintain the unit costs if the model is still a fee for service.
Yeah, thanks, David. That's really helpful. We're getting some audience questions coming in here, so I want to just turn maybe to Carolyn first. There's a question here from Art Spivey about recommendations on how to fund community health workers if they're meant to help patients inside and outside the hospital and with social determinants related unmet need, meeting some of those unmet needs, and what's the role of insurance companies and health plans in paying for community health workers? What's your view on that?
Yeah, you know, we've found great success in that at Milena, and actually the program started out of New Mexico many years ago, but then Milena took that model and spread it nationwide, where we do pay for you know, people that are embedded out in the community. We call the program our Community Connector program. And we really rely on those folks to help us with a high cost, high need population in terms of linking them to services that are going to, you know, that group of services called social determinants of health, to really be able to help maintain people in the community, but also to help link them up with other programs. And so at Milena, we actually employ those folks. We contract with entities who provide that care. And I do think if you're in a state who has Medicaid managed care organizations, the best first step would be to reach out to them and meet with them, talk about the overall program that you've got running, as David was talking about, you know, in terms of a bundle of services, so that you're able to then quantify what that bundle of services is going to bring back to that insurance company or that managed care organization in terms of reducing costs. So, you know, examples of that might be if you have community health workers who are, for example, out in a rural community, but they know where to get housing supports and they know where to get food supports or employment supports for people, but they're also going to monitor and help work with your members, your insurance members, to, you know, monitor their care, so that they're meeting with them on a regular basis. They're alerting the managed care company back to issues that they might find around their medication management, or a change maybe in some other type of housing situation or in their environment that's really going to affect their healthcare situation. And so I think if you can kind of build that program and then approach your insurance companies with that model, you're more likely to get some type of funding for it. Again, we've found great success in that. Our community connectors, for example, out in the Navajo area, meet on a regular basis with our members at the chapter houses. They work with them to make sure that they're getting food that they need. We've started a program called RX Food Box, where that food is then tailored to the person's healthcare condition to be able to help them stay in the community. And sometimes that means that the community connector is bringing you know, the local food pantry access to the member, or linking that member there, or we're figuring out how to pay for that food box to be delivered to that member. So I think there's a lot of research out there that shows that it's effective. So if you can work to kind of bundle that package together, again, as David was talking about, meet with your insurance companies and be able to provide that array, I think there is research that shows that it's cost effective to be able to do that and link people back to those community-based type services for care. help in terms of helping to reduce their healthcare costs.
Yeah, thanks very much, Carolyn. Let me pose this kind of this question to you, perhaps starting with Ken. One of the key questions that I think healthcare service providers or healthcare organizations and social care organizations face, perhaps in this country more than any other, is a separation between them and no real accountability frame that surrounds them necessarily at this time. Some of these newer payment models, I think, starts to link health and social care providers into structured arrangements that start to create that kind of alignment. But I'm curious from your perspective about where you think the role of healthcare begins and ends, and the role of social care begins and ends, and what's the relationship between these two that you're seeing on the horizon as an important element of the need for complex care? And let's start with you.
Well, yeah, I mean, it's as Carolyn and David have talked about, it's a huge opportunity. The spectrum between what's social, environmental, financial, and what is medical needs to be a more seamless continuum. So in the models that we've been working on with community-based nurse care management, part of our approach is to ask that nurse to be accountable for the full range of all potential determinants of health that might affect a patient and their family. Obviously, as amazing as those staff are, they can't do that alone. And the issue of connecting them with community services and social services is a huge piece of the role. And what we find is that it's not enough to, as we often do in the medical side of things, which doesn't work either, just make a referral and hope for the best and assume that the problem will get solved. That both on the medical side and on the social service side, including behavioral health and addiction services, you've got to, someone needs to relentlessly follow through and shepherd that along. And I think some of the more effective models are going to increasingly have either technologic systems and or humanware that's going to make sure that happens. Further integrating those services into new and better models in terms of robustly integrating those capabilities in the community is a design opportunity. I mean, we were just talking with a group in our region this morning that really focuses on the home support services, non-medical, everything from cleaning to social visitors and volunteers and a whole array of things that we haven't focused on in our nurse care management model. I mean, I think bringing those kinds of designs together in a more integrated way, and as was spoken about before, bundling that in a coherent offering that can be priced and contracted for, and then ultimately evaluated to have an ROI is I think where we need to keep heading.
That's great. Very helpful. There's a question here from Marissa Scalafoli, who's asking a question about the way I characterize it is the build, buy, or partner question. About social care and healthcare integration. What drives your decision to partner and contract with community-based organizations versus either purchasing or partnering to achieve them or building them yourselves? What makes how do you do that analysis? What factors weigh on you as you're trying to decide how to make these relationships? David, maybe I can start with you and your experience at Ascension. How do you guys think about this?
So I think we've used a variety of different models in how we've approached it. I think probably the first step is recognizing that if you're going to be successful caring for the population, it's going to require a multifactorial intervention. So, for example, somebody who needs housing, if they get housing, but they don't have medicines, they can't get to the doctor, and they don't have the right diet, it's not going to work. And so if we take a heart failure patient. And part of the issue is that I don't think individual health systems or payers for that matter are in a position where they can solve all the problems. We have to take advantage of the community organizations that are in place and build on the ability to work with them to have the interventions. What doesn't work as well is making simply grants where you can't quantify what the impact is. You have to be able to quantify the impact in order not to just simply create a model to see if it works, but to create a long-term sustainable model that has a stable financial and funding base. So I think it's first recognizing what are the issues that need to be addressed, and then recognizing who in a specific community can help you address those. And what you find often is that individual partners in community can often address more than one individual determinant. And typically, although I don't have any real data to support this, the sense I have is that it's maybe 4 or 5 community partners as a group, for example, can effectively provide most of the services you need.
Yeah, great. I wonder if you could. So one of the key challenges with figuring out, you were describing kind of the model that you might try to put together to sort of find the right service, or identify what services are needed, find the partners that are out there, some of which may provide multiple services, and then build a kind of argument, if you will, build a business argument around the expected return. One of the challenges that a lot of these programs face is, of course, the time horizon. I think Ken, you mentioned that in the initial. The return expected may not, especially for some of these early stage social determinants, might not pay off for quite some time down the road. How do you deal with this notion of a delayed return on investment? Just Carolyn, Ken, what are your thoughts on this? Carolyn, do you want to start for this notion of delayed returns that come later?
Did you say, I'm sorry, I'm not sure if you said Carolyn or Ken, but I'll start off. You know, that's tough because coming again from the, government role that hat I used to wear, the legislature wants to see those types of things and those services pay off within the year because they're working on your budget in that time frame, and the governor that you're working for and the legislature want to see it in that time frame. So what we try to focus on in terms of talking to legislators and governor's offices is that sometimes you're going to end up bending the cost curve. Your costs aren't going to go up as high, and you're not going to see the savings right away in that first year drop. It's going to take a little bit more time to see that change, but you are going to start to see in the first year some of that cost savings in terms of reducing the cost curve. And then I think we also try to put together data, and this is something everybody's going to have to bring to the table in their community that shows that. And you can really do that with even, inside your system with a sampling, if you are able to get the backing to launch some of these pilots. So for example, we had one health plan that really wanted to do something to meet the state's needs around serving the jail population. Because of the Medicaid expansion, we now have more low-income adults accessing services, but they also have more run-ins sometimes with incarceration. So we had one health plan that wanted to do that. We gave them technical assistance to start a pilot with the jail to where when folks came out of the jail system, we linked them quickly to get their prescriptions, to get their counseling appointments set up, to get their Medicaid eligibility going and rolling, and that way reducing the cost. So we took that population and measured it against the population that wasn't participating. And we were able to show that by working with the jail system and the program, linking those people to housing services, especially getting their medications set up as they're coming out, especially if they have addiction or substance abuse issues, that's really key and important. And then getting them into therapy, whether it be counseling or medication assistance therapy for addiction treatment out in their community, that was key in terms of reducing some of the costs. And we saw two things. One, a reduction in recidivism back into the jail, which saved the government money, didn't save Milena healthcare money necessarily, but the government officials liked that. And that's something you can show, within that year period of time, of course, that we'd like it to go on further out there. And then also, I think the other thing is you can quickly look at utilization of that population and show, compared to the population that doesn't participate, a reduction in ER use. And those are kind of the key factors. If you can show some of those high cost programs going down, you're going to be able to show that reduction in overall care. But again, it is going to be spread, frankly, over a longer period of time, not always in the first 6 months of a program.
Great, thank you.
And Ken, I don't know if you want to add on to that.
Yeah, no, I appreciate your answer. And I guess I would be even a bit more cautious, maybe based on our experience and some of the literature, is that sometimes needful populations that have been under attended to, under monitored, under assessed, actually wind up having a spike in utilization initially when you outreach to them and you identify needs and you get them plugged into care. We've seen that ourselves. I think the VA had done some studies years back that showed some of that. And in our case, actually utilization initially for a population of chronically ill older adults went up for the first 12 to 18 months after intervention, including elective cardiovascular procedures and stents and things like that. And initially, I thought this was going to be an absolute disaster because the stories I would get was that the nurse would show up at the home and there'd be an older gentleman hanging onto the mailbox, sweating and looking ashen and complaining of a little chest pressure. And, all the right things were being done to expedite their care. But what we saw later in the data at the 2.5 year mark, the utilization lines really crossed over, and the folks that were getting admitted in the usual care group were winding up being admitted with emergency, in extremis, resuscitated in the field, spending days in the ICU. And it was a very different distribution of semi-elective or non-emergent evaluations versus emergent. So I think it takes a real systems thinking approach to sort of, be prepared to do this work and a constancy to purpose on the part of leadership. And I think the best way to help support them in staying constant to that purpose is thinking about the possibilities, understanding the populations you're serving, and just really being diligent in tracking the data in ways that can help you kind of reveal the story of what's really going on.
Well, when I was listening to David, I think it was you that was speaking to this point earlier, but there's this, and it gets at this point around the delayed ROI. A lot of this centers around, we've had a system for a long time that rewards based on fee for service or volume. And we're trying to, in some ways, transition to risk-based arrangements or situations in which we're either experiencing capitated payment or have a full risk for an accountability for a population. In lieu of a kind of full movement to that latter reality, which we're all living in a present state that's sort of in the balance. Jennifer Miles asked a question on the chat here about the fact that most of the goals of these complex interventions are about reducing utilization of high-cost services, which has an impact on our bottom line. They're sources of revenue for the most part for a lot of our systems today. How do we deal with this? How do we navigate in this current time? Is it about waiting for the future of value-based contracts and accountability frames, or is there a way to make it work in our present state right now? David, I wonder if I could ask you this question.
Yeah, so I think it's a great question, and that's the reason I gave the example with the heart failure admissions. The impact of that in our system is tens of millions of dollars on the contribution margin side. The impact on the revenue side is much, much greater. And so somewhere between right now, the reduction on the revenue side, all credits to the payer. And somewhere between the credit to the payer and the contribution margin, there's still a huge gap and a huge difference that could potentially make it far more profitable for both a payer and a health system to engage in that kind of work. And then the question is, how do you move that ball down the road? And then as Ken is talking about, how do you measure it in a way that's realistic so that your benchmarks and what you're using and attributing risks and other pieces make sense? But I think you have to start from the standpoint of saying, well, there is a win here. The right care is the win. And then we have to think about how do we manage that. I think the same thing is true with the time horizons. I understand that everybody wants to see everything in a year, but that's not always the way it works. And so we have to be open and thinking about it. And at the end of the day, if we were all operating from the same model in terms of the churn that occurs both in delivery systems and in health plans, if everybody was trying to work through that and get through that, probably wouldn't matter. It would probably all even up at the end of the day. So it's really, and I think employers have a bigger stake in this as well, because employers can be looking at this. And depending upon different types of employers, have different rates of turnover in their population. And so I think there are different perspectives that can be taken and different partners that can be viewed, but there has to be a willingness to look at it.
Thank you, David. That's very helpful. I mean, on this score, Carolyn, you've done a lot of work on in government, trying to help shepherd some of these more value-based arrangements and at least test and trial them. I'd be curious to hear where you think policy is headed. Do you see it? Do you see it headed in the direction of more of this kind of effort? Do you see more statutory flexibility coming into play with Medicare and Medicaid to use healthcare dollars to pay for some of the social care needs that we talked about earlier? Where do you see policy headed in the future?
Yeah, prior to this call, I think I would have said maybe not so much flexibility on Medicare and Medicaid side, that it's going to have to be done between the insurance companies, the payers, and the states to drive value-based purchasing towards these types of services, or drive to putting what we would call, social determinants of health or in lieu of services into capitation rates and payments. But surprisingly, this morning I get up and read about North Carolina's waiver being approved and pilots being allowed for housing and employment. So I do think, with, efforts around things like the Better Care Playbook, with efforts by the National Governors Association, the Association of State Medicaid Directors, AHIP, and the managed care companies there continuing to push in this area, that we're going to continue to see more flexibility and integration of these types of programs. For folks who've done healthcare system work for a long time, we've seen things like value-based purchasing, going back to the 90s, right? And taking off for periods of time. And I think as people start to now reflect on those models and including social determinants of health of them, including kind of the risk sharing arrangements, but also then seeing the better outcomes, being successful and being a win for both patients, which is of course the most important thing, the payers, whether it be state agencies or Medicare at the federal level. As we start to see those better outcomes, there's going to be more of a drive in this area to keep moving in that direction. So it may not happen quite as fast at the national level in terms of the support that we want, but I think the innovation being driven out of by the state partners, the local providers there, the managed care companies that are working there to push that forward, I think we're going to continue to see that intervention and those changes coming down the pike.
Thank you. That's helpful to hear, and it'll be heartening to hear. It's absolutely the news coming out of North Carolina and other states suggest anyway that there's lots of innovation that's at play at the state level around the policy environment to help support some of these activities. So thanks for that idea. Ken, in your opening remarks, you mentioned you referred to measurement and the complexities around measurement around this work. I wonder if you have experienced or look at specific performance indicators, key performance indicators related to care management or complex care strategies that you think matter the most in terms of driving financial commitment to complex care. What's your view on what measures seem to matter with respect to the financial questions that we're wrestling with here?
So I maybe sort of counterintuitive answer to that is actually for the team that's responsible for implementing the model of care that we're talking about. We actually try to buffer them almost entirely from the financial issues and focus really, really hard on the execution of the design of the model with high reliability. So our metrics around operational performance are pretty intense and pretty robust, and they include a lot of statistical process controlled charting, looking at variation from our guideline standards and nurse to nurse and region to region operating performance. When it gets down to translating that into what happened on the utilization and the financial impact side, that's a huge piece of work and very important, and we're engaged in that too. But we kind of separate that a little bit from what we ask the care team on the ground to keep their eye on, and how we manage that. When it comes to that other piece, we're trying to get more creative in ways that work in the context that we're implementing. So, for example, in one setting, we've been using waitlist control groups. That these are groups that with the data identified as having equal likelihood of benefiting from the program based on their risk profile of chronic illnesses and utilization patterns. We referred those lists out to the primary care docs. They said, yes, go get them. And then we start randomly pulling those names off those lists to go outreach to. And so the folks that are in the waiting phase are a pretty good match in terms of everything short of a randomized controlled trial that we can do. And we've tried to apply those kinds of approaches, and there's plenty of limitations on that that I won't get into, but as many ways as we can to triangulate around a comparison group that seems valid, reasonable. There are lots of other matching tools statistically to try and construct those groups, and to try and build those into the day-to-day operational analytics, which is what we've been working a lot on now, because it's really hard to wait for a year of sort of resolving the claims data run out and then trying to get together and looking in the rear view mirror that far back. So that's really been the focus of what we've been trying to work on now as far as that goes. But we pretty much keep the analytics between the financial and utilization side of things and the operational team side of things separate, but robust for both as best we can.
Okay. Yeah, that's helpful. One last question from one of our participants here who's asking, says that they were just in a meeting and they found that a question has surfaced around how important predictive analytics. You're mentioning some of the analytics on the other end of the spectrum of kind of analyzing the performance of some of these care models, but how important is predictive analytics and machine learning on helping us all identify patients with complex health and social needs, or some what's considered the rising risk, those who will eventually become those with complex needs, and how they might benefit from interventions. What are you seeing today, David? Perhaps starting with you, what's the role of predictive analytics and machine learning in your work today in helping this?
Yeah, so I think the role is going to be very important in the long term. I think the insights into individuals and how they are different and how they interact with the world is different. I think we're seeing true generational changes in how people want to receive their healthcare and interact with their healthcare. We've got mobility now that's universal, that was non-existent in the 80s and early 90s. We've got other examples of ways that we can take advantage and intervene. And there are different populations and different people that want to be interacted with in different ways. And so being able to understand how you do that and how you can be effective in that and have technology platforms that can support it at the same time that you're improving your learning, I think are going to be really important. We've done a number of things in these dimensions in terms of what we've looked at. I also think, though, that, it's interesting. I listened to Ken's comments. I absolutely agree. That's why I said, caregivers should be focused on the right care model. And we need to step back and figure out how do we make the business model support it, which is what I heard from Ken. And so I think the predictive analytics are going to be important, but, medical progress has really been predictive analytics from day one. It's always been about trying to understand what works and doesn't work and how do you improve and then demonstrate that in a reliable way.
Great. Well, thanks. Thank you, David. We're now almost at the end of the time we have for this webinar. We want to say to close. I'm going to ask each of the panelists to just give us a short sort of takeaway of what you thought was some of the most important aspects of this problem from your experience. So we'll start with you, Ken. Give us your sort of final word on this issue.
Well, as I think we've all touched on, it's a broad topic with a lot of complicated pieces, but I think the fundamental commitment to improving the health outcomes of populations of people that, David started with as well, has got to be the driving force. It's got to be the force that leadership, believes is the reason for us working on this. And the other piece I would just offer is that, diligent design and very disciplined implementation is going to be key. That it's nice to talk in generic terms about roles and determinants of health and so on, but when it comes down to actually implementing and seeing the impacts, there's a lot of discipline detail that goes into these models, and there's a lot of ways that can kind of go off the rails if you're not really able to keep a management discipline around that. So it's more than just some key concepts. It's a lot of how-to and know-how that's going to need to be built into this work.
Great. Thank you, Ken. Carolyn, your last word.
I think as our population continues to age and live longer, we have to really work in our healthcare systems, whether that's working with states who have policy authority over some of these programs or at the national level with the federal government, to make sure we're able to have a more integrated care system for folks to be able to move them back into the community and help reduce the cost and with wrapping services around them. And to do that is whether it's payers or providers of care, I think we need to be innovative in our approaches. And I really encourage people to do that, to work with those that have oversight of your healthcare system, but be innovative. Think about how you can bundle together some of these services, whether it's around housing or employment or nutrition services, back with what the care is of the member and what they really need, and be innovative in bringing that information to the table, and continuing to push people forward in this area, because I think we're going to get there. It just takes some time.
Thank you, Carolyn. And the last word, David, from you. Go ahead.
So we've been talking a lot about lowering costs for populations and improving outcomes for populations, and trying to improve the experience that those individuals have, which is really the triple aim. We have a fourth aim that we call the quadruple aim in our system, which is around caregiver satisfaction. And I think we have to, the caregivers want to provide the right care. And in fact, we've burned out a lot of caregivers, and we have to do the interventions and the designs in a way that fits within the workflow and the approaches for the caregiver, and try and reestablish that joy that caused many caregivers to go into medicine in the first place. So the only other comment I'd make is, let's not forget about the caregiver as we do this work in the design.
Well, thank you to all three of you. Just a very quick recap of some of the major points here. From Ken, we've heard about the commitment to improve outcomes, such a critical part of this. From David, just do the right work and the money will follow in some ways, and we can make it follow, but the importance of doing the right work, I heard loud and clear. And from Carolyn, the policy level, especially at the state level in places like North Carolina and elsewhere, where there's considerable innovation and activity to help us support some of these care models that we think are going to be important, including things like building bundles that allow us to link health and social care together. So just really grateful to all three of you for all of your efforts in your organizations, as well as in the national dialogue around improving care for individuals with complex needs. Thanks to all three of you, and thank you to the audience for joining us. It's been a great discussion. I'd like to once again thank the 6 foundations that have supported the development of the playbook, which we mentioned at bettercareplaybook.org. That playbook will continue to host discussions like this one about what it takes to make care for complex individuals better and financially viable. So stay in touch with us at that website at www.bettercareplaybook.org. And then my last word is that we frequently cite these financial constraints as the showstopper around complex care. But as you can tell from the discussion that we've had today, there are many organizations, including those represented by our 3 panelists, that are addressing this challenge and doing it in a sustainable and successful way. It can be done, and we look forward to hearing from all of you. Have a wonderful day. Thanks.